My disclosures are available on the AAOS website. So keeping in with the theme of the conference, adapting and evolving, I thought we'd touch on the evolution of rotator cuff repair. So we began with an open approach, and that evolved towards a completely arthroscopic approach. And through the introduction of anchors, we've evolved the different arthroscopic approaches to include single row, double row, suture bridge, and finally now transosseous techniques that can be done completely arthroscopically. So just to anchor ourselves for this discussion, what we're talking about are two different techniques here. One is the transosseous equivalent approach, both done arthroscopically. The transosseous equivalent involves the placement of these medial anchors just lateral to the articular margin, and then passing the sutures through the rotator cuff, and finally bringing those sutures over into a second row of anchors into the lateral greater tuberosity. Compare that to a fully transosseous repair that doesn't involve the use of anchors, but similarly places a vertical tunnel just lateral to the articular margin and then connects that through the use of this device to a lateral horizontal tunnel, allowing for the passage of sutures again, and then typical rotator cuff repair. So the case was selected here is a 63-year-old gentleman who's a recreational swimmer and an office worker who's had 2 prior rotator cuff repairs. We see his MRI here, both coronal and sagittal views, full thickness, large tears of both the supraspinatus and infraspinatus. He's having some weakness, difficulty with some daily activities, pain, overhead activities, and well-maintained joint in terms of the joint services. The muscle grade was good, some mild atrophy and fatty infiltration. So we selected a revision repair with a transosseous technique. This allowed us to place these tunnels around prior anchors that were placed from prior surgeries, and allowed us to select different sutures to execute the repair. The disadvantages, of course, are the learning curve and managing this technique. So this is a video. We use a standard beach chair positioning with a 4-portal techniques, beginning with our diagnostic arthroscopy from the posterior portal. Entering the joint, this is a right shoulder. We see the prior sutures from the old surgery. The biceps tendon is still intact. The tuberosity is empty from the large tear. The subscapularis tendon is intact. Again, just a reminder from the imaging. We place an anterior cannula to allow for irrigation and instrumentation. And then we begin our debridement first, removing the old sutures, preparing the greater tuberosity footprint, removing the remnant tissue from the greater tuberosity, and then finally the old sutures as well. So we did this from an anterolateral portal using a grasper and a biter to remove some of the old sutures, allowing us to then focus on the preparation of the rotator cuff. So here's the cuff mobilization. We release some of these scars in the subdeltoid space as well as underneath the cuff. This is the glenoid, releasing scars of the tendon to the glenoid to allow for easy mobilization and a low tension repair. We continue the preparation with the tuberosity and remove the remnant tissue with the ablative device, and follow that with the bony preparation with a standard burr. You can see those old holes are from prior anchors. So using a transosseous technique allows us to avoid those and maintain a maximal bony footprint. I also prepare the lateral gutter and continue to assess the rotator cuff tendon, which is mobile and clearly repairable. So this is the medial tunnel. A typical awl is used to place just lateral to the articular margin. It's the simple device that connects that medial tunnel and allows you to place a lateral connecting tunnel for your suture passage. And you can see that coming in on the right. This is a device externally. There's a simple bone punch that goes through the device and places a passing suture. This suture can be used to place your definitive sutures of your choice in each tunnel. We selected a 2-tunnel technique as pictured here with 3 sutures in each tunnel. And then the rotator cuff repair proceeds as standard with various techniques to pass the sutures through the tendons and then simply tying knots across the tendon repair site. You can cross the tunnels and connect them to achieve a high strength fixation of the rotator cuff back into the tuberosity. So you can see the completed repair here, and you even see an old anchor that was placed from a prior surgery. I just wanted to touch on some of the literature for this approach from a biomechanical and a clinical perspective. So when we talk about different rotator cuff constructs, it's well established that an anchored transosseous equivalent construct does have a higher failure load, but the anchorless fully transosseous approach can also achieve high failure loads, over 450 newtons. The failure mechanism is quite different between these two techniques. The anchorless technique tends to fail in a type 1 manner, meaning the tendon becomes detached directly from the bone, compared to the transosseous equivalent anchored approach where you have a type 2 failure, which is a muscle tendon junction failure. So this is a picture of that type of failure on the right, the muscle tendon junction failure, and we saw that much more frequently in our biomechanical study in the anchored approach compared to the tunnel approach. When we did a systematic review and meta-regression looking at all these different biomechanical papers, over 40 papers were identified, and we looked at all the different covariates, particularly suture type, the number of sutures, the number of actual suture limbs passed through the tendon, the number of mattress stitches, and even number of anchors. And finally, the construct type. Was it a single row, a double row, a transosseous, or a suture bridge type? And then we looked at failure load and mode. What we found is simple, really. It's really all about the suture. So the strongest predictors of repair strength are the number of suture limbs or sutures passed through the tendon, as well as the type of suture. So wide dimension sutures such as tape are preferable and lead to greater strength. And when you control for those parameters, any construct is effective. So there's no difference in rotator cuff strength between construct types. Our other findings again suggested that the transosseous anchored repairs are associated with those type 2 muscle tendon junction failures. Another important area is the contact area and compression when we talk about rotator cuff healing. So there's some additional potential advantages of transosseous repair that allow for a large contact area, favorable compressive patterns, and contact pressure to enhance healing. And there is some ability to do this now without medial row compression. So some additional studies for an anchored approach are needed to see if that can get back to our original gold standard when done open, which was fully transosseous. With respect to our clinical experience, we did a matched cohort study to evaluate long-term outcomes with respect to clinical scores such as the ASES pain scores. When we matched these for over 2 years follow-up, there were equivalent results, both with respect to the ASES score at 1 year and 2 years, the pain scores, as well as range of motion and function. And finally, ultrasound evaluated rotator cuff healing. Both groups achieved equal healing rates, and re-tears really had much more to do with rotator cuff size initially. The main difference being, however, there's significant cost differential between an anchored approach and a transosseous approach, which only requires an instrument and no additional implants other than the sutures. So as the rotator cuff size increases, the cost differential can be quite substantial. So the final takeaway points from a biomechanical perspective, both a transosseous and a transosseous equivalent anchored approach can attain similar strength. And it's really about the number of sutures and suture types that predict that. But the type 2 failures are much more common in that anchored approach. Clinically, the results are similar, both with low re-tear rates, but arthroscopic transosseous approach does represent higher value due to lower costs. Thank you.